pneumonia. But for most patients, Ecmo may be used to decrease the intensity of mechanical ventilation. This is something we have described with Dan Brody and Ards in this JAMA review paper, where the technology might be used to minimize lung stress and strain, mostly by decreasing tidal volume, the pressures, the plateau pressure, the driving pressure, which is the plateau pressure minus the PEEP, the respiratory rate, altogether decreasing ventilator-induced lung injury, which is made of volutrauma, barotrauma, atelectrauma, which is the opening and closing of the alveoli, and biotrauma, the high production of pro-inflammatory cytokine and by the inflamed lungs and alveoli. And when looking at the recent literature, we have good evidence that one of the key elements might be actually the driving pressure. Once again, the plateau pressure minus the PEEP, with a threshold, let's say, above 15 centimeters of water, above which this mortality increases exponentially. But there's no apparently safe threshold for this driving pressure, with mortality seeming to decrease steadily once the driving pressure is reduced, maybe below 10 or even below maybe up to only 5 centimeters of water. And there might be also a rationale for decreasing the respiratory rate. It's written in guidelines that it may be possible to increase the respiratory rate up to 35, maybe up to 40 in some patients to control respiratory acidosis. This actually may be associated with worse outcome in the patients. These are very important data derived from the Lung Safe database, in which mortality increased by 3% per additional breaths per minute of driving pressure, maybe above a threshold, which probably is around 25 to 28 centimeters of water. But still, this is something we need to take into account. And these elements may be integrated into the concept of mechanical power, which represent the whole energy which is transferred to the lungs and the alveoli, which takes into account the tidal volume, the driving pressure, the flow, the PEEP, and the respiratory rate. The formula here is a little bit complicated, but it may be simplified and calculated at the bedside. And probably what is the most important here, once again, is the driving pressure, the tidal volume, and the respiratory rate. And it has been suggested that there may be also a threshold in terms of mechanical power, which is expressed in joules per minute, let's say above 15 to 20, above which, once again, the mortality exponentially increases. And when looking at patients who are initiated on Ecmo, and this is data from a very large prospective cohort of patients, the lifeguard cohort with 350 patients on VV Ecmo, when the mechanical power was calculated just before Ecmo, it was between 20 and 30 joules per minute, so way above the potential thresholds for much higher mortality. And look here, after minutes of Ecmo, it was possible to decrease the intensity of mechanical ventilation, and this mechanical power dropped down to below 10 joules per minute. So now the questions are, when do we need to initiate Ecmo in patients with ERDS? Which is the population of patients? Where should we conduct this activity? And we now have a lot of answers when looking at the recent literature. And first, we need to think about Ecmo very early in the course of the disease to rapidly decrease the intensity of mechanical ventilation. It's probable that the longer the wait, the higher the mortality because of increased ventilator-induced lung injury. These are data from our center, which showed that the mortality increases by 7% per additional day of mechanical ventilation awaiting ECMO. So it's probably not necessary to wait days of injurious mechanical ventilation to think about ECMO. And in that series of patients, the mortality was significantly lower for those patients who got ECMO within 3 days of intubation as compared to those who got ECMO much later on, let's say between 5 and 10 days and way above for those who got ECMO more than 10 days after being intubated. And once again, when looking at this respiratory parameter just before and after ECMO was initiated, there was a strong rationale to think that this benefit might derive from a decrease in the intensity of mechanical ventilation. Look here, driving pressure was above 20. It was decreased to around 12, same for the tidal volume, for the Prato pressure. And once again, looking back at the lifeguard cohort, it was also shown that the driving pressure, which is probably one of the most potent predictor of mortality in these ARDS patients, was significantly reduced as soon as the minutes following ECMO initiation. So now, where should ECMO be conducted? ECMO is still a complex procedure using complex technology. It's not only about cannulation, it's all about the management of the patients for days, sometimes weeks in the ICU. And we have strong evidence that the higher the number of ECMO cases a year, the lower mortality. Here are data derived from the ALSO registry, suggesting that a number of cases of at least 30 is needed to reach the best results possible for this activity. So the next very important question now is which population of patients should we include in this technology? Should we initiate ECMO? Looking back to the EOLIA study, which was published now 3 years ago, the entry criteria were 3. 2 were criteria of very severe hypoxemia, a PF ratio below 50 for more than 3 hours or below 80 for more than 6 hours, despite potential use, not necessary, but potential use of rescue strategies such as nitric oxide recruitment maneuvers or prone positioning. And the third criteria was respiratory acidosis with a PaCO2 over 60 for more than 6 hours, resulting from loss of compliance, need to decrease the tidal volume, need to increase the respiratory rate to control dangerous mechanical ventilation. And we included, as you remember, 124 and 125 patients in ECMO and control group. In that study, the age was around 50, and those patients were quite sick with a SOFA, which was close to 11. And we did include patients very early after intubation. It was only 1.5 days after intubation. And the causes of ARDS in the EOLIA trial were mostly pneumonia, and at that time were mostly bacterial pneumonia. And there was around 20 patients who had viral pneumonia, bacterial pneumonia, pneumococcal pneumonia, staph pneumonia, Legionella pneumophila were the main causes of ARDS in these patients. Other causes were classical causes of ARDS, such as pancreatitis, aspiration pneumonia, all the types of sepsis, for example, secondary ARDS caused by sepsis. The PF ratio in EOLIA was 72 on average. The study showed a strong trend towards benefit in terms of mortality at day 60, which did not reach quite statistical significance. The p-value was 0.07, very close, with an 11% absolute reduction of mortality from 46 to 35% in ECMO patients. And when looking at the key secondary endpoint, which was death in ECMO patients or death or the need for rescue, crossed over to ECMO for control patient. This time, there was a significant and major difference between the two groups, 35 versus 57%. Not only about mortality and treatment failure, all these key secondary endpoints and outcomes were also in favor of the ECMO group. There was less days with the need for vasopressors, less days with cardiac failure, with dialysis, with renal failure, with the need for prone positioning, or the need for rescue nitric oxide. Those ECMO patients did much better, actually, than did control patients. In the follow-up of the Eolia trial, we took a close look at key subgroups of patients. And actually, I was very surprised to see that it were not those patients with the most severe forms of the disease which benefited the most from ECMO. When looking at the PF ratio, 66 was the median. The most benefit in terms of mortality was for those patients who had the PF above the median, 27% mortality versus close to 49%, and it was highly significant here. Altogether suggesting that it may have been possible to include patients with a bit less severe disease, let's say PF less than 100, like in the Berlin definition of ARDS. Second, when looking at the three key inclusion criteria, the 2 PF ratio criteria and the pH PCO2 criteria, the most important benefit was also for those patients who had severe respiratory acidosis with a loss of compliance, probably a major dead space also as well in these patients, and a strong trend towards the benefit. Of course, it's post-hoc, of course, it's subgroups, but this is very interesting here in terms of what population of patients benefit the most from this technology. Later on, we reanalyzed the data with Bayesian models, and we confirmed that the probability of ECMO saving lives in severe ARDS patients was very high, probably over 90%, depending on the different types of prior hypotheses which were made. And this is why the editorial which came with that paper concluded that clinicians and researchers should no longer ask, does ECMO work? Because that question appears to be answered, yes, ECMO works, ECMO saves lives in patients with severe ARDS. Instead now, we should determine from how much does ECMO work, in whom, at what cost. These are the open questions. Following the Eolia trial, we also worked with Giles Peake, which was the PI of the CESAR trial, a former trial of ECMO conducted in the UK 10 years ago. And we conducted a systematic review and individual patient data meta-analysis of these two trials. And this time, when combining the two trials, gathering more than 400 patients, the benefit was highly significant in favor of ECMO. And we also analyzed some of the key subgroups and confirmed that it was probably not the most severe patients who benefited the most here. When looking at the number of failing organs at randomization, was those patients with only 1 or 2 organ failing. It means that only 1 organ on top of respiratory failure that had a strong gain in terms of mortality with ECMO was not the case of those who had 3 or more organ failing initially. We also confirmed that those patients who got ECMO were better off in terms of days with vasopressors, days with renal replacement therapies. This was highly consistent between the two trials. A few words now about what has occupied the whole world in the last 18 months, COVID-19. As many other teams in the world, we were confronted to that disease in late February 2020. And when the first cases came to our country, especially in Paris, we decided to define inclusion criteria for Ecmo and basically relied on the EOLIA entry criteria. But we defined also maybe more strict contraindication for Ecmo in terms of age. There was no age limit in EOLIA. At that time, we defined an age limit around 65. We also limited for supermassive obesity for patients who had severe comorbidities or severe immunocompromised status. Of course, patients who had cardiac arrest before ECMO. We also limited the duration of mechanical ventilation to 10 days, with maybe some little flexibility for very young patients, but it was a criteria which was applied to most patients. And of course, also for those patients who had multiple organ failure, maybe except some of those who had initially acute kidney injury, because it's one of the features of the disease. And this is the first experience we reported just in one center here in La Pitié-Salpêtrière in Paris, showing that the day 60 probability of death was around 30%, very close to what was observed in the EOLIA trial. However, there was some differences between the two types of patients and the two types of disease. COVID-19 is for sure not a traditional form of ERDS, with a longer duration of ECMO support, which was close to 3 weeks 1 year ago, and also very long ICU stays, almost twice longer as it was the case for the EOLIA patients. Also more complications, specifically more ventilator-associated pneumonia in these patients, probably linked to the very long duration of intubation and ECMO support. Also, we did prone much more patients during that time without knowing exactly for now if this is associated with the benefit or not. More recently, we published the experience of the Greater Paris in those days of the first wave of the disease in France from March to June 2020. There were more than 570 calls to our centers to have a decision, a potential decision to go to ECMO, of which 302 were approved. And most of those, 2/3 of the patients received ECMO with the mobile ECMO rescue team. And the survival rate was actually much lower in this population of patients. It was only 46%, as it was close to 70% just looking at data of patients treated in our center in La Pitié-Salpêtrière. And when looking at the multivariable model and those factors associated with mortality, age was a strong predictor with good prognosis for those patients who were less than 48, and much lower survival rate for those who were above 57 to 60 years of age. We confirmed that the number of days of mechanical ventilation from intubation to ECMO was also strongly associated with mortality, with a much better outcome for those patients who got ECMO less than 3 days after intubation. And we also confirmed data from the ALSO registry about the number of cases. The mortality was only 35 for those patients treated in high volume ECMO centers, those who treated more than 30 VV, not all ECMO cases, VV cases the year before COVID. And the mortality was twice higher in those centers treating less than 30 patients the year before COVID. Lastly, mobile ECMO retrieval was not associated with worse outcome, which is very reassuring for the organization as a network in this during this pandemic. More recently, we reevaluated all the calls we got during this first wave of the pandemic last year. Once again, we got close to 600 calls to our regulation hub here in La Pitié-Salpêtrière, and we defined 3 groups of patients. The first group of patients was called Ecmo no never, because there was no indication, so as many contraindications. And looking at the survival rate of those patients was very low, around only 10%, which is quite reassuring about also our indications. And for those who got ECMO yes or ECMO not yet, maybe prone the patient, maybe adjust mechanical ventilation and call us back in a few days. The 2 groups of patients, ECMO yes and ECMO not yet, at the same survival rate, which is also very reassuring. Even more recent data, not quite published yet, but it seems that the survival rate of the patients treated during the second wave of the disease was mostly during last winter, including some patients after January 1st who got infected with the alpha variant of the disease, had higher mortality. This is only our center. Once again, the mortality was around 30 to 35 in the first wave. It reached close to 50% with the second wave. And we are now collecting data, patients treated during last 2 months when the Delta variant hit France, and the mortality of those patients may be also much higher than previously reported. So in conclusion, when to initiate ECMO? When it's the right time, for sure. But first, we need to remember that ECMO does not kill people, because when I designed the EOLIA trial 10 years ago, this is what was believed by a lot of intensivists. And ECMO is actually very likely to benefit to patients with severe ARDS, probably for now, using the entry criteria for the EOLIA trial. Once again, we need to work on additional studies, maybe to have a bit less strict entry criteria in terms of PF ratio, but this should be submitted to other trials. It's also very possible to say, well, not yet, especially for those patients who did not receive a trial of prone positioning. It's also possible to say no to ECMO for those who have a very low probability of surviving because of advanced age, comorbidities, organ failures, duration of mechanical ventilation. We need to build networks. ECMO cannot be conducted in every ICUs. There is a volume outcome issue here, and we need to have networks discussing for the decision, treatment optimization. There's need also for efficient ECMO mobile team to retrieve patients on ECMO. And last but not least, we need to improve the way we treat these patients. We need maybe to define once again what is the population which is going to benefit the most. We need to work on the best strategy to ventilate these patients. Is it useful to prone these patients on ECMO? We are conducting right now here in Paris and in France the prone ECMO trial, which randomizes patients to prone or not proning under ECMO. So there is a lot of questions remaining. And with this, I would like to thank you for your attention. It was a great pleasure for me to attend this meeting. And I'm available for any questions you might have. Thank you so much again.